Hello everyone, this is Shad Reis from CVI 2025. I'm really privileged to be with Dr. Victoria Odeleye to talk about challenging case in a cath lab. Thanks
Thank
for being
you.
with us. So here, like the dissection case,
Yes,
very
I did.
challenging.
Yes,
Yeah,
yeah,
tell us
very
about it.
challenging. So we had a 35-year-old female who came in postpartum. She was 1 week postpartum, came in with chest pain. She had no prior cardiovascular history or history of complicated pregnancy. And when she came in, her troponin was elevated, like peaked at like 100s and then downtrended. She did have like some ST changes in her lateral leads. So we did suspect, SCAD in this patient just based on her clinical presentation as well as her, postpartum presentation as well. So we took her to the cath lab. When we got to the cath lab, she did have left main SCAD. She also had LAD and RCA SCAD as well.
All left main and RCA.
Left main LAD and RCA.
Oh.
Yes, so she had multi-vessel SCAD. So we weren't quite sure how to approach this when it comes to either conservative management or revascularization. Because the guidelines are not very clear. So because she was hemodynamically stable, we just decided to treat her with beta blocker antiandrogens, and she did well in aspirin. And then we discharged her on about day 3.
And there was a Timmy 3 flow all the way to all
Yeah, there
arteries.
was still flow, TIMI3 flow all the way through.
And you said troponin was 100 or 1000?
Yeah, like 111.
Okay.
Yeah, 111. And then we discharged her, but she presented back 3 days post discharge with chest pain. And this time she had ST elevations in her inferior leads with some reciprocal changes. At the time when she initially presented, she had like nitroglycerin, the aspirin, but then her ST elevations kind of resolved. So we thought maybe this could be vasospasms from all the inflammation. But then we kept giving her multiple nitroglycerin, then it would resolve, and then she'll go back to the ST elevation, and we're just like, this doesn't feel right. So we called our sister hospital who activated the cath lab, and then we got her to the cath lab, and then she arrested VFib in the cath lab, but we were able to achieve ROS very quickly. And then we decided to do another diagnostic, and she had occluded her PDA or PLV, and then her LAD was significantly progressed dissection. And then, luckily enough, we had already talked to the cardiothoracic surgeons. They activated the OR, and then they just wheeled her off to the OR. And then she got triple vessel bypass. She got a vein graft to the LAD actually, and then SVG to the PDA, and then SVG to an OM branch. The reason why they didn't do the Lima is because of like their spontaneous healing, and they didn't want to use like a good vessel for that bypass, so they just used a vein graft just in case she heals and then the graft fails. At least it's just a vein graft.
Right.
And this was like a teaching opportunity for us. I think this was actually M&M in our institution as well, in regards to should we have taken her earlier when she initially presented, given that she did have a left main. And then there's just been like data. There was like a systematic review that came out in April of 2025 in regards to patients that present with left main, and there have been some link with pregnancy and left main dissections as well. And based on that systematic review, based on 130 studies actually, they saw that early revascularization was superior to conservative management in this patient with left main dissections. And I think it was a teaching opportunities for even our interventional cardiologists that are not very familiar with these cases
So
on how
what we're
to approach
suggesting that
this.
you should be stented the first time?
Yeah, stented or cabbage
bypass.
for left main, yeah, or bypass surgery. But when you look at the sub-analysis in regards to PCI and bypass surgery, bypass surgery still takes precedence just in regards
The
to
age.
like the complication of PCI with very frail vessels. That her vessel per the cardiothoracic surgeons was very fragile. And I can just imagine putting a stent into that would have been disastrous.
How was
Yeah.
her EF before she left the hospital?
It was preserved.
Okay,
Yeah,
good.
she was
All
like
right.
60%.
And mentally
yeah.
it was fine and everything's good.
Yes, yes. And she actually presented weeks later with chest pain, got us very nervous, but her troponin was negative. We got a CCTA. Her grafts were still preserved,
Awesome.
actually. Yeah.
Great. Well, great
Yeah.
case. Thank you so
Yeah,
much for
yeah.
sharing,
Thank
Victoria.
you so much for having
Yeah.
me. Thank you.
Congratulations. This
Thank
is Shad
you.
Reis coming to you from CVI 2025 in Austin.